comorbidities, peer pressure, younger age, and low socioeconomic status. As far as the clinician or the healthcare provider factors, unfortunately, choosing a medication without really thinking about the side effects, without taking that into account, insufficient education around the illness and the importance of taking medication, complex dosing regimen and polypharmacy, not developing a good therapeutic alliance, and fragmented care. So let's look at the patient's perspective on what's important to them from a recent major depression study. This is a large study. It was an online study using the 24-item FAST questionnaire, which is a functioning assessment questionnaire. Large number of patients, over 2,000 patients with MDD, over 1,000 healthcare providers, including primary care physician, psychiatrist, and neurologists. And the survey you can see here was conducted all around the world in many different countries, including the United States. And the study looked at the perspective of the patient and the treating healthcare provider in each of the three phases of recovery from depression: the acute phase, the post-acute phase, and the remission phase, focusing on three areas: the perception of the symptoms of depression, second was the impact on function, and third was on overall treatment goals at various phases of the illness. Now, before we get into the results, we have a question for you. We'd like to get your perspective. What proportion of your patients do you believe still experience mood, physical, or cognitive symptoms while in the remission phase? Is it number one, 0 to 19%, number two, 20 to 39%, number three, 40 to 59%, number four, 60 to 79%, or number five, over 80% of your patients? Please go ahead and submit your response.
60 to 79%, or number five, over 80%.
You know, this reminds me, Andrea, that we're asking people to vote, and in America next week we have a very big election, a presidential election, and of course we're encouraging all of our friends and colleagues in America to vote as well in the election.
Right. I heard that many people have already voted, right? Are you voting also by mail and also in person? There is some people voting earlier. Is that correct?
Yes, my wife and I have already voted. We went to an early voting location so we could vote. And we're breaking records.
We'll see what happens.
Yeah.
In the meantime, let's see what our colleagues will answer. We have people connected from all over the world. Here they are. Basically, so you asked what proportion of patients in the remission phase were still experiencing mood, physical, and cognitive symptoms. And what I can see from their answer is that 44.3% reported that between 40 and 59% still have symptoms. 43.1% that between 20 and 39%, and also we had approximately 10% of them that reported that more than 60% of patients still had residual symptoms. So quite a lot of patients had these symptoms.
That is a lot, yes. All right, well, now looking at the results of this large survey, what we see is, unfortunately, there's a disconnect between the patient's perception and the healthcare providers. Healthcare providers tend to understate or underestimate the symptoms, especially in the remission phase, across all three of these domains of symptoms of MDD, whether mood, physical, or cognitive, and you can see the results here. So we need to do a better job, especially when patients are in remission phase, of assessing for these residual symptoms. And especially if you look at the cognitive symptoms, the domains of difficulty concentrating, remembering, and difficulty making plans, again, this difference is especially evident in the post-acute and remission phases, again, calling out the importance of us really monitoring for these residual cognitive symptoms, which are so important. Now, patients have similar hopes for treatment regardless of what phase of depression they're in here. So if we look at whether it's the acute, the post-acute, or remission phase, patients really value functional goals, returning to a normal family life, normal social life, and working life. So a recovery, a return to normal, feeling normal and normal function, whereas lifting the mood symptoms is the next. And then notice a significant chunk want to reduce side effects, Also, in the acute phase, patients particularly felt that cognitive symptoms were related to their functional impairment, whereas later on in the post-acute and remission, they felt that not only the cognitive symptoms, but the rest of the symptoms also were involved with function. So the importance of treating all of the symptoms, but especially cognition. Whereas healthcare providers' goals for treatment, they actually change and evolve a little bit over time. In the beginning, they tend to really especially value mood even more than function, and then function begins to take over later on. Notice that a significant chunk in the remission phase, 14%, felt that no treatment goal was necessary at that point. Everything's fine, they're in remission. And notice also they tend to underestimate the importance of minimizing side effects compared to the patient's views. Also, the healthcare providers did not only feel that cognition was as important in the acute phase with respect to impaired functioning. Now, patients and healthcare providers have different perspectives of treatment success. This is from a large study done by our friend Kern de Metier. And what Kern found was that there was a disconnect here in what people felt that treatment success looked like. You can see the physicians tended to value most the symptoms of depression. Patients valued the symptoms of depression, but not as much. That was not their top priorities. Their top priorities had to do with emotional wellness. What extent is life meaningful? How much are you enjoying life? How satisfied are you with yourself and self-esteem? That was valued less so by healthcare providers. And then you can see there were other things as well, including concentration, that are valued by patients. And so we have a question based on these findings and this disconnect between healthcare providers and patients. How likely are you now to incorporate these findings into your practice? Would you say, number one, you're not likely to do that? Number two, somewhat likely? Number three, likely? Or number four, very likely to incorporate these findings? Please vote.
You know, Andrew, while we're waiting, I was thinking that very often we choose a treatment for our patients based on what we would choose for ourselves in the same situation, but we end up just deciding for them. Sometimes it would be a good idea to just ask them what their priorities are, because sometimes Absolutely. They're not similar to ours.
I agree, and one thing I always ask is, what side effect would trouble you the most? And you'd be surprised. They don't always say the same thing. Some people, for instance, it's nausea. Some people, it's weight gain. Some people, it's sexual dysfunction. And I can sometimes incorporate that into my treatment planning as well.
Yeah, that's very important. And you're right, side effects are very different in terms of how much they worry each patient. And we should not assume that each patient wants to take the risks that one of us would like to take in the same situation, as opposed to the risk for a different side effects. So let's look if the people that are watching us found something new that they may incorporate in their practice, or if what we said is something that they already did. And it's very interesting because a very large part of them, more than 80%, responded that it's very likely or likely that they will incorporate these findings in their practice. So I think that you said very important issues.
Yes, I'm glad to hear that. All right, moving on further, looking further at patients' treatment priorities. This is a study from a man that I know, Mark Zimmerman, and what he found was that the majority of the factors that are considered very important include positive mental health, such as optimism, vigor, self-confidence, also a return to a usual level of functioning at work, home, and school. So emotional wellness and function are very important. And then also important was the absence of symptoms of depression, a little less important to patients. And what patients are looking for is emotional functioning and cognitive functioning, which they relate to feeling well and doing well, and ultimately to this concept of being well, of wellness, and improved health-related quality of life, which is something that's important to measure in clinical trials. And as far as longer-term goals from the patient's point of view, patients focus on functional improvement, as we said, but also improvement in emotional stability. And as you can see here, the importance of relationships, romantic, family, and social relationships, improving physical health, improving cognitive ability and function both at home and at work finding a job. Restoring function is a key treatment goal in the CANMAT. These are the Canadian guidelines. What you see here is the Canadian guidelines divide into an acute phase, which is the first 8 to 12 weeks, and then a maintenance phase, which is 6 to 24 months. The question in the acute phase is, how do we get patients well? In maintenance, it's how do you keep them well? And the goals you'll see here in the acute phase, of course, are remission of symptoms, but then to restore functioning. And then in the longer term, it's a return to full functioning and a full quality of life. Patients want to recover and be back to the way they were before, and then prevent a recurrence, of course. Now, how can we help patients achieve their treatment goals using vortioxetine? Well, vortioxetine is an extremely well-studied medication, as we'll show you. So what we'd like to do, of course, with a medication is help resolve all of the symptoms, including emotional, physical, and cognitive, and get to functional recovery, both functioning and quality of life, that sense of wellness and emotional well-being. And in clinical trials, we have measured these things, but again, we focused especially on measuring symptoms with our traditional rating scales, a little bit on function. But now there are a lot of other scales, newer scales that can be used to really delve into some of the particular functioning and quality of life. And these are some of the scales that were used in the vortioxetine clinical trial program. And vortioxetine is one of the most extensively studied antidepressants that I've ever seen, going beyond symptoms and really looking especially at real-world importance of functioning and quality of life. And so, in the REVIVE study, vortioxetine was shown to be effective over a period of 8 weeks in the short term at improving function as measured by the Sheehan Disability Scale, total function as well as family life, work, and social life. And it was superior to agomelatine, another antidepressant. And in the longer term, up to 52 weeks, up to a year, you can see that the improvement in functioning was sustained and actually improved a little bit over time. Now, there's another functional scale that I think is really important because it's very practical. It measures everyday practical functioning. It's called the OOPA. If you look at the bottom here, you can see the OOPA measures household chores, communication, finance, transportation, and planning recreational activities. And what we see here is vortioxetine is superior to placebo at improving these measures of function, but it's also superior to duloxetine and SNRI. Now, another unique rating scale here is called the Depression and Family Functioning Scale, the DFFS. And this scale is a 15-item scale. It's a self-report from the patient. The first 11 items have to do with partner and family interactions, as you see on this slide. And the last 4 have to do with the quality of the relationship with your partner. And we total those together to get an overall family functioning total score. And what we see here, again, in the REVIVE study, is that vortioxetine was shown to improve quality of life on the left as measured by the EQ-5D, the Euroqual. Also work productivity, the work limitation questionnaire in the middle, and the DFFS, which is the family functioning scale. And again, it was superior to agomelatine at improving these important measures in the real world. And when we use another quality of life scale, the short form 36, we can see here that vortioxetine, especially the 10 milligrams, was superior to placebo at improving these domains. And I want to highlight especially the mental health index, emotional role, social functioning, and vitality. So really, especially looking at that sense of emotional well-being and emotional wellness. And a large study called the At-Work study that especially looked at functioning at work. These are patients who either started with vortioxetine or were switched from another antidepressant to vortioxetine. And what we see here is improvements in cognitive symptoms and function. So on the left, we have objective measure of cognitive performance, the digit symbol substitution test. We have the patient's subjective impression of cognition using the perceived deficit questionnaire for depression. And then we have the workplace productivity is improved, and overall functioning measured by the Sheehan Disability Scale that we've seen before. Also at the At-Work study, whether patients started with vortioxetine or switched to it, We saw an improvement in absenteeism, which is time away from work, but also presenteeism, which is being at work but not being productive. So real-world functional outcomes here improved with vortioxetine. And then for patients with a history of trauma, which are patients that are especially hard to treat, we see that vortioxetine improved the symptoms of MDD, also function and quality of life. And this is a long-term study of up to 48 weeks or almost a year. And we see here we improved the symptoms of depression measured by the MADRS, the Montgomery-Åsberg Depression Rating Scale. Also symptoms of anxiety, which are very important because many patients with depression have anxiety, especially those who've had a history of trauma. Also functioning measured by the Sheehan Disability Scale, and health-related quality of life, as you can see here. So I want to now conclude and give you a summary of what we've been talking about. Half of patients do not respond adequately to our initial treatment with an SSRI or SNRI. Patients with partial response have significant impairment in their overall functioning, and they have worse outcomes. The goals of treatment depend on the phase of the illness and the individual patient's needs, and physicians and patients differ in their views as to what they consider important for recovery. So we need to try to incorporate the patient's perspective and treatment goals. And patients tend to focus especially on functional improvement and emotional stability or a sense of wellness and recovery. Vortioxetine can help patients achieve these treatment goals by improving overall function and quality of life and wellness, as demonstrated by a variety of measurements as we saw in the vortioxetine studies. So I'd like to leave it there and turn it back to you, Andrea.
Thank you. Thank you very much. And it is so true that we have patients that improve and improve well, but we have a large number of patients that do not improve enough, that remain with residual symptoms, and those symptoms end up impacting their ability to function, their quality of life. So we have to decide what to do with those patients. When do we have to switch treatment? When we can titrate the dose up of a medication that we're using for the treatment of depression? When we should augment the treatment, adding another medication? So now we will look at a brief video, and then we can talk about this issue, you and I, and then we can answer any question that the people that are watching us may have. But let's look at this video first. So, Andrew, the first question that I have for you is when, meaning how long should we wait before we decide whether we should switch, titrate, or augment? How long should we wait if we see that the patient still has residual symptoms or doesn't respond as well as we would like him or her to respond?
You know, when I was trained, we were trained to wait at least 6 to 8 and even 12 weeks to assess for response. And I think that's just too long. We don't have that much time to wait. Newer data suggests that if you don't see at least a 20 to 25% improvement within the first 2 to 4 weeks, you need to do something. And what that something is depends on the clinical situation. Obviously, either raise the dose, switch, or augment. But I would say that we should be more aggressive and reevaluating even earlier than many of us previously thought.
Yes, I agree completely with you. My second question is what? What should we do? Should we switch? Should we titrate? Should we augment? When should we do one, the other, or the other option?
Well, unfortunately, the data, as we saw, is not really clear, so it really becomes a clinical decision, and this is what we call the art of medicine. I think if a patient is tolerating a medicine well and there is room to increase the dose, certainly you could consider that, although there's some data you're going to present that says that doesn't always work for antidepressants, but it can for vortioxetine. And then if a patient is having a partial response, sometimes you don't want to lose the gains you've gotten, and so you might augment. But if a patient is really having a very inadequate or not much of a response at all, then you would consider switching.
And again, I agree very much with you. Let's now look if they have some questions, people watching us, if they have any question for us. Let's see if we have questions from them. The first one is this. What is unique about the health-related quality of life data for vortioxetine?
Well, first it's unique because many other antidepressants don't have it. And also it's unique because the times when it has been studied very often, certainly in the acute studies of the 6 to 8 weeks, there are many studies where antidepressants did not beat placebo on health-related quality of life, whereas vortioxetine has consistently shown that improvement across different studies and different rating scales.
Do you think this may have anything to do with the fact that usually vortioxetine is very well tolerated? How much tolerability impacts on quality of life?
Well, this is an excellent question because as we saw, patients tend to come off of they don't stay on their medications. We saw that by 90 days, 50% have stopped their medicine. And the number one reason when we looked at the reasons for the patient was side effects. So I think you're right, a drug that has less side effects or is better tolerated, it's more likely patients will keep taking the medication even once they start feeling better.
Yeah, this is true. Now, in terms of titrating the dose up, there is a question about what the dose is of vortioxetine that you recommend. What is your target dose? Yes. When do you go to the maximum dose?
I now recommend 20 milligrams should be our target for essentially every patient, assuming that they're tolerating the medication. And usually what I do is I start at 10 milligrams, and I go for about 2 weeks because it takes about 2 weeks to get to steady state, and also that's a good time to reassess. And then I would go up to 20 milligrams, assuming that the patient has room for further improvement and is tolerating the medication.
Yeah, this is perfectly consistent with what we do here in my clinic, and it is consistent also with the data from clinical trials that we will review in the second presentation. But there is a colleague asking, how soon do you change the dose of vortioxetine from 10 to 20 milligrams?
Yeah, I go, again, about 2 weeks is what I look for. Sometimes I'll go faster if the patient is not responding well or was really sick and I really want to be more aggressive, so maybe after a week. But typically for me, it's about 2 weeks.
And then we have a very interesting question. How about patients that have major depression and severe anxiety? What is the efficacy of vortioxetine for patients with depression and severe anxiety?
Well, it turns out there actually was one positive study for vortioxetine on generalized anxiety disorder, but it's not approved for that use. You need 2 different studies, of course. But in my experience, and if we look at the study I showed, the patients with trauma, it did improve the anxiety symptoms as well as the depression symptoms, and that's been my experience. One of the properties that I especially associate with vortioxetine is an anti-anxiety mechanism.
Yes, this is very interesting and consistent perfectly with what I see as well. Now, what are the main reasons why to switch from SSRI to SNRI, and how do you do the switch? Sorry, from SSRI, SNRI to vortioxetine, and how do you do the switch?
Well, I do like to switch. In the United States, we often have to start with a generic SSRI or SNRI first because a brand name medication is not covered initially. So I very often then use vortioxetine as my first switch because I feel like if I switch from one SSRI to another, it doesn't work as well for me. So the way I switch is I'm going to start vortioxetine sometimes at 5 milligrams because we're overlapping serotonergic mechanisms, and I go for 2 weeks and then increase to 10 milligrams. With the SNRIs and paroxetine in particular, they have significant withdrawal symptoms if you go too fast. So I would taper those over 3 to 4 weeks, whereas other SSRIs, I typically taper off after 1 to 2 weeks.
Okay, do we have any other question, or maybe we can go ahead with the rest of the presentation, then we will answer to the other questions at the end of this second presentation, if you agree.
Yes.
So we'll talk now about dose-response relationship among antidepressant treatment options and vortioxetine. So we'll look at the relationship between the dose and response for all antidepressants and for vortioxetine. Basically, we'll look at the clinical evidence suggesting the appropriate dose of vortioxetine from both fixed dose randomized clinical trials and flexible dose studies. We will look also at the other antidepressants. We look at how to determine the optimal dose of antidepressants in clinical practice. So again, in summary, we will try to understand the relationship between the dose and efficacy of antidepressants, between the dose and adverse effects of antidepressants, and then how to balance the benefits of a higher response rate with higher doses if we see that higher response rate and the risk of more side effects. And we will look at whether there are differences between vortioxetine and the other antidepressants in terms of what happens when we increase the dose. Let's look at the differences in the mechanism of action. Now, SSRIs primarily work by blocking the reuptake of serotonin, so inhibiting the reuptake of serotonin. Vortioxetine does the same, inhibits the reuptake of serotonin, but also has direct effects on specific receptors. Specifically, it has agonistic activity on 5-HT1A receptor, which is very important to treat depression, to treat anxiety, but it also has antagonistic activity to very important receptors like 5-HT3, 5-HT7. 5-HT3 is very important, for instance, for emotional blunting. We know that one of the main problems of SSRIs and SNRIs is emotional blunting, the lack of that emotional wellness that you were talking about. So people with emotional blunting are feeling numb, are feeling as if their emotions were anesthetized. They don't have positive emotions, they don't have negative emotions, they lose their creativity, they don't care about what happens outside because they're unable to react to positive emotions, to develop positive emotions. They're unable to react to positive stimuli, they're unable to react to negative stimuli, and their functioning is impacted very much because of their inability to care for what happens around them. Actually, many patients complain about emotional blunting with SSRIs. We recently completed a study because in clinical practice we saw that this was not happening with vortioxetine, but as a matter of fact, vortioxetine was able to treat emotional blunting. So we evaluated these in a multi-center international trial we recruited patients with emotional blunting and depression, patients that had not responded to an SSRI, SNRI, and we treated them with vortioxetine, and we were very pleased to see that the majority of these patients improved very much in emotional blunting. Actually, 50% of those patients were without emotional blunting at the end of this 8-week study, and the other 50%, the great majority, improved a lot. This is linked probably from a pharmacodynamic standpoint to this antagonism to 5-HT3, because the increase in serotonin in the GABAergic interneurons usually decreases norepinephrine and dopamine transmission. But if you block 5-HT3, as a matter of fact, you don't see a decrease, but you see an increase in norepinephrine, in dopamine transmission, and many other neurotransmitters. So this is interesting because in our trial, we saw that patients improved in their depression, and there were patients that were resistant to treatment with SSRI, SNRIs, and we had 62% of those patients that improved on vortioxetine, and interestingly, the majority received 20 milligrams. We'll talk about this dose again in the next few slides. But most importantly, in addition to improving in their depression, they didn't experience emotional blunting anymore. So they recovered from emotional blunting. But let's go back to the mechanism of action. 5-HT7 is another very important receptor on which vortioxetine works as an antagonist. And these may have a lot to do with its ability to improve cognitive functions, to improve attention, concentration, memory, executive measures of cognitive functions, and this may be one of the reasons why it is so good on functioning. Then we have SNRIs, which are medications that block the serotonin transporter, that block the norepinephrine transporter. Now let's look at these medications and at what happens when we increase the dose of the medication in terms of efficacy and in terms of side effects. Here you see SSRI, SNRIs at the commonly used doses. What happens in terms of occupancy of the serotonin transporter? So you can see that SSRI, SNRIs, if you look at the doses that we generally prescribe, they tend to occupy approximately 80% of the transporter. So citalopram between 20 and 40 milligrams, you see that it occupies around 80% of the transporter. Same thing for fluoxetine within the usual range of dose of 20 to 60 milligrams, same range of occupancy. Sertraline between 50 and 200 milligrams, exactly the same. Paroxetine between 20 and 50 milligrams, exactly the same. Venlafaxine, same exact thing at doses between 80 and 225, 300 milligrams. So we see that the occupancy of the transporter for these medications is around 80%. Let's look at what happens when we increase the dose. This, for instance, is for fluoxetine. If you see that you increase the dose of fluoxetine from 20 to 60 milligrams, and you see the first part on the left of this figure, you see that you increase the dose, but in terms of outcome, you don't see an improvement in efficacy. So the number of patients that respond to 20 milligrams is similar to the number of patients that respond to 40, to the number of patients that respond to 60. But the side effect, the dropout because of side effects, dramatically increase as you increase the dose. Look at the figure in the middle. How many more patients drop out from studies because of side effects as you increase the dose of fluoxetine from 20 to 60 milligrams? Let's look at venlafaxine, SNRI. For venlafaxine, when you increase from 75 to 150 milligrams, you do see some improvement in efficacy. But when you go above 150, you no longer see this improvement. However, you see a big increase in the dropout rate due to side effects. So again, here, the deal about raising the dose is not so good. Now let's look at vortioxetine in terms of receptor activity, in terms of activity on the serotonin transporter, and in terms of the relationship between dose and tolerability and response. First of all, this is a medication that doesn't work only on the serotonin transporter. The action on the serotonin transporter is very important, but it is not the only one. As you can see, vortioxetine works on the transporter, but also works on 5-HT3 receptor, 5-HT7, 5-HT1A. How much of the transporter does it occupy depending on the dose that we are prescribing? With 5 milligrams, you get approximately 50% occupancy of the serotonin transporter. With 10 milligrams, you get 65%. To arrive to occupy more than 80%, as it happens at the standard doses of the SSRIs, you need the 20 milligrams. So again, if the target is an 80% or more occupancy of the serotonin transporter, 20 milligrams is your dose. But how about efficacy on specific symptoms? What are clinical trials telling us in terms of what happens as we increase the dose? Here you can see in this study, they looked at how each item in the Montgomery-Åsberg Depression Rating Scale improved with different doses of vortioxetine. So in orange, you see 5 milligrams a day, then green, you see 10 milligrams a day, violet 15 milligrams a day, and dark blue 20 milligrams a day. And as you can see, the dose of 20 milligrams is the one that leads to the best improvement in basically, at least numerically, basically all symptoms measured by the Montgomery-Åsberg Depression Rating Scale. So you see that there is a greater magnitude of effect for 20 milligrams. Here again, you can see another study that looks at response, meaning improvement in Montgomery-Åsberg Depression Rating Scale by at least 50%, or remission, and both in studies conducted in the United States and in studies conducted outside the United States, these two measures improved more. There were more patients that improved, that achieved response with 20 milligrams compared to other doses. So again, 20 milligrams seems a much more powerful dose than 5, 10, or 15 milligrams. Let's also look at results in other studies, like the study that you, Andrew, mentioned earlier, the study that looked particularly at the ability of patients to go back to work, at how the medication was able to improve depression in patients that were working, and also it looked at the type of job that patients were doing. Look at the differences of vortioxetine 5, 10, 15, 20 milligrams in all patients, in working patients, or in professional patients. If you look at the one right before the last on the right, that is vortioxetine 20 milligrams, you see that the difference from placebo of 20 milligrams, especially in professionals, but also in working people, was much, much greater than the other differences, at least numerically greater. So it's clear, it's consistent that 20 milligrams is working better. Even in the study with those patients difficult to treat, you said exactly the correct thing, that had a trauma and that used vortioxetine at different doses. You look at 20 milligrams in patients with any trauma, patients with childhood trauma, patients with recent trauma, gave a very, very good response, in most cases better than the other doses. But what's the deal about side effects? Do we have to pay a price for keeping the majority of patients on 20 milligrams if 20 milligrams is the best dose for vortioxetine for many patients? Well, the good thing here is that vortioxetine is one of the best tolerated medication. If you look at the number, the patients that experienced side effects in more than 5% in clinical trials, those side effects that had more than 5% of patients experiencing that side effect, and when that percentage was at least twice as much as the percentage of patients on placebo, we had only 2 side effects for vortioxetine that were present in 5% of patients and in a group of patients that was twice as much as the patient on placebo that were experiencing the same side effects. And there were nausea and vomiting were not that many. For nausea, we can see that it increases as we increase the dose. However, this is basically the only main side effects that we may see with vortioxetine, because this medication is unlikely, as you can see from this figure, to give sexual side effects, unlikely to give anticholinergic side effects such as dry mouth, constipation, urinary retention, unlikely to give weight gain, unlikely to give the other side effects that you can see here. It's a very well tolerated medication. And again, this may be one of the reasons why patients are stabilized on vortioxetine. They achieve a good quality of life. They don't have to pay a price in terms of side effects, like, for instance, sexual side effects that are very important when somebody is stable, like, for instance, weight gain, like, for instance, emotional blunting, that is a very high price that many patients on SSRI, SNRI have to pay once they arrive to maintenance treatment. Here, the only one side effect that you see increases with the increase in dose is nausea. But in my experience, if a patient doesn't have nausea on 10 milligrams, and actually the percentage of patients that have nausea on 10 milligrams is not that high, especially if you can start at 5 milligrams, or if you give them some days, because usually nausea is mild or moderate, and within a few days, for the majority of patients, it tends to disappear. But people that do not experience any nausea on 10 milligrams, in my experience, is extremely unlikely to experience nausea on 15 or on 20 milligrams. So again, at the beginning, when vortioxetine was introduced in the market, I thought that 10 milligrams were the dose that was the dose where most of patients should arrive. Nowadays, the majority of my patients go to 20 milligrams because you see greater magnitude of response, more patients that will respond, and more patients that will achieve complete remission with 20 milligrams as opposed to just 10 milligrams. But this is just what I'm doing here. I'm very interested in knowing if this is something that happens also to the colleagues that are watching us, or if many of them tend to use lower doses. So we have a question for you. And basically the question is, what percentage of your patients on vortioxetine are on 20 milligrams a day? 1, less than 10%. 2, between 10 and 50%, 3, 51 to 80%, 4, greater than 80%. What percentage of your patients are on 20 milligrams a day? And while we're waiting for them to tell us about how many of their patients are on 20 milligrams a day, Andrew, maybe you can tell us, in your experience, do you see any difference between those patients that stabilize on 10 milligrams and those that stabilize on 20? Do you go straight on 20 milligrams or you prefer to wait? And usually, who are the patients that need higher doses?
Well, my experience is similar to you. When the medicine was first available, I probably had most of my patients on the 10 milligram dose, and I felt that that was good enough. But since now I've seen the data, I would say the vast majority of my patients are I'm pushing up to 20 milligrams. And I agree with you that tolerability is very good, especially if I wait 2 weeks, at least 2 weeks. In the clinical trials, the dose was started at 10 milligrams, and if you were randomly assigned to 15 or 20, you went up after only 1 week, and that's before you get to steady state. So I find I get better tolerability when I go 2 weeks. As far as what kind of patients, I've gotten more aggressive at asking about residual symptoms, and I find especially that patients who have some residual cognitive impairment or the emotional blunting you talked about, lack of motivation, those are sometimes the patients that I really get aggressive. But really any patient that I feel like doesn't have a complete remission, I'm going to try to push higher, and that's been my experience since I've been doing that it does work better.
Yeah, I agree completely with you. Let's look at our colleagues, how many of their patients are on 20 milligrams a day. Let's look. So we see that approximately 40% are on less than 20 milligrams. no, let's see, less than 10%, 40% of our colleagues. 38% reported that among their patients, 10 to 50% were on 20 milligrams, are on 20 milligrams. We have 18% of our colleagues that report that 51 to 80% of their patients are on 20 milligrams. So these are similar, I think, to us. And actually, we have 5% of patients that report that greater than 80% of their patients are on 20 milligrams. And this is exactly what I see. My patients, the great majority of them are on 20 milligrams. Because even when you see that they are improved, if they've not improved completely, you push the dose to 20 milligrams and you see a difference. And those patients that do not improve on 10 milligrams, usually I always try 20 before giving up.
You know, another situation when I push is when I see residual anxiety. I find pushing to 20 can also help with the anxiety.
Yes, that's definitely a good point, especially when patients have like obsessive compulsive traits.
Yes,
I mean, that type of anxiety requires usually higher doses. Absolutely. Let's now look at flexible trials with flexible dose. I mean, those trials where physicians were able to increase the dose. Let's see at what happened, what they decided, how many of their patients received 20 milligrams, how many received 10 milligrams. So one of the studies that you mentioned is the CONNECT study, the study that was looking at cognitive functions of patients' ability of vortioxetine to improve cognition, to improve depression, to improve functioning. Another study that we will look is the other one that you mentioned, At Work study, that was looking at the benefit of vortioxetine in improving depression in people that were working, in the ability of sending back people to school, sending back to work. And the other interesting study is the Revive study. And this study is the study that you mentioned earlier, patients that were actually not responding to previous SSRI, SNRIs, and were randomized to vortioxetine or to agomelatine, and vortioxetine was significantly better than agomelatine. And then we have our study, the complete study, that is the study evaluating emotional blunting, and basically this one study looked at how much emotional blunting improved, but also patients were able to receive 10 or 20 milligrams. Now let's look at the results of this study. How many of these patients were actually receiving 10 milligrams, 20 milligrams? What were the mean doses in these trials? In the CONNECT study, the mean dose was 16 milligrams a day. So it was not 10 milligrams, not 20, but pretty high dose. At Work study, again, physicians pushed the dose to a mean dose of 15.2 milligrams a day. Revive study, we had 64.7% of patients that were on 20 milligrams a day. So much more than half of the patients, this study were patients that were resistant to previous SSRI, SNRI, 64.7% were on 20 milligrams a day. In the complete study on emotional blunting, 51.4% ended on 20 milligrams a day. So again, it's very important, this one Revive study, the one with patients that were resistant, the great majority of them, 65%, received 20 milligrams a day. In the complete study, a relatively large number of patients received vortioxetine 20 milligrams a day at week 1. 50% of the patients received it at week 4. So again, when do we have to increase the dose? In this study, 30% of the physicians decided to immediately raise the dose to 20 milligrams. In this study, we had very, very low discontinuation rates for vortioxetine at week 1. Very few patients discontinued vortioxetine. It was actually very much tolerated. Large number of patients improved on this medication. And again, relatively many patients, more than 50%, received 20 milligrams. So, as far as SSRIs are concerned, we know that increasing the dose is not related to increase in efficacy. There is not a relationship, a linear relationship between dose and efficacy, but we see an increase in side effects. So for SSRIs, it may be a good idea to switch relatively early if a patient doesn't respond. As far as vortioxetine is concerned, fixed dose randomized clinical trials showed that doses of 10 and 20 milligrams were associated with significantly greater reduction from baseline versus placebo, but they also shown that a higher effect was consistently shown at 20 milligrams of vortioxetine, and most importantly, increasing the dose of vortioxetine to 20 milligrams was not associated with an increase of adverse events that are commonly observed with antidepressant treatment. In flexible studies, physicians chose vortioxetine 20 milligrams a day for most patients. In the REVIVE study, 65% of patients received vortioxetine 20 milligrams a day at week 5. In the complete study, 27% of patients received vortioxetine 20 milligrams a day at week 1, and only 3% discontinued due to treatment adverse effects. So let's review these data. Let's see what we can say about these data, how we can translate them in clinical practice. And I wanted to have your opinion about these findings, dose-response relationship among antidepressants. And again, we can talk again about what we are talking at the beginning, switching, augmenting, or making the simple increase in the dose. So adding another antidepressant, adding another medication, increasing the dose, or switching medication. How would you do in a patient that is taking an SSRI, an SNRI, compared to a patient on vortioxetine? Would you do differently based on this data, or do you think we can establish a rule that is the same for all antidepressants?
Well, I think this data is very impressive and, is changing my thinking. I previously did think I could increase SSRIs, SNRIs, and get better responses. So I may now not do that. I may actually switch sooner off of an SSRI or SNRI, whereas with vortioxetine now I'm much more likely to increase the dose as my first choice when I have an inadequate response.
Is there any particular patient for whom you suggest using a lower dose, like elderly patients or patients with anxiety at the beginning? Do you use different strategies for titration?
That's exactly what I do, what you just said. Elderly patients, those with significant anxiety, they tend to have more side effects and not tolerate drugs as well in the beginning, although I'm still going to try to push the dose eventually higher. And then those, when I ask, what are the side effects that bother you the most? Those who say nausea, really, I'm really afraid of nausea, really don't like nausea. Sometimes those I'll start at 5 milligrams. And sometimes when I'm switching from an SSRI or an SNRI over to vortioxetine, sometimes I start at 5 milligrams there because there's an overlap of serotonin mechanisms.
Yes, I agree with you. And I think that one thing is how quickly you go up, and one thing is what the highest dose that you reach is. So for instance, as you were mentioning before, for patients with depression and comorbid anxiety, very often we start on a low dose because these patients are very sensitive to side effects. They monitor their body constantly, and so it's better to not raise the dose too quickly. But then the target dose is not different. As a matter of fact, as you said, probably those patients will need higher doses. Same exact thing we've seen for patients with emotional blunting, because if you raise the dose to 20 milligrams, many times you see a huge change. You see patients that improve in their interest, they improve in their ability to enjoy things, but they also improve in their reaction to external stimuli. And the improvement that we see in emotional blunting is definitely greater for the majority of patients on a higher dose as opposed with a lower dose. This doesn't necessarily happen for the majority of the other antidepressants.